Thyroid diseases. Thyroid gland pathophysiology. The thyroid gland is mainly stimulated to synthesize and release thyroid hormone by TSH. The thyroid gland releases and also produces into the circulation at least two potent hormones. The two potent hormones, thyroxine and triiodothyronine. These two hormones produced by the thyroid gland influence the basal metabolic processes and enhance oxygen consumption in nearly all body tissues. Identify the epidemiology of your disease in BC. Studies suggest that 5% of women and 1% of men have thyroid nodules detected in a clinical setting. In British Columbia, routine thyroid function is not highly recommended in patients who are asymptomatic. In BC, within the laboratory, we look more at TSH values. If the initial TSH testing turns out to be normal, a repeat test is unnecessary unless there is a change in the clinical condition. If a woman is pregnant or planning on pregnancy, then a TSH test is suggested if she has any risk factors. Key risk factors for the development of your disease. Some risk factors for thyroid disease are being female, being over the age of 60, recent pregnancies, having an autoimmune disease, family history of thyroid diseases, personal history of thyroid problems such as goiter, type 1 diabetes, pernicious anemia, drug therapies such as lithium, past history of iridation, rheumatoid arthritis, and past thyroid surgeries. Initial investigations and ongoing tests. Some of the initial tests for diagnosing thyroid disease are called thyroid antibody tests, T3 tests, T4 tests, TSH tests, ultrasounds, thyroid scans, radioactive iodine uptake tests, or a physical exam. First initial labs to diagnose thyroid disease is a blood test. If the thyroid stimulating hormone is higher than another, test is done again, along with a blood test for the thyroid hormone, T4. The main medications for thyroid disease is levothyroxine sodium, a synthetic version of thyroxine, T4. Ongoing test panels measure levels of TSH and T4 in your blood. This is for determining whether your current treatment plan is working properly for your thyroid disease. Pertinent signs and symptoms that a nurse should be aware of. Signs of hypothyroidism include neuropsychiatric, such as depression or a decreased mental function, neuromuscular, such as physical tiredness, paresthesia, hypokinesis or hyperflexia, physical appearance or voice, such as weight gain, coarse, dry skin, periorbital edema, and hoarseness. The thyroid gland, such as goiter, thermoregulation, diminished sweat or cold intolerance, ophthalmic signs, which there are no signs or symptoms, gastrointestinal, which is constipation, pituitary function, such as menorrhagia, and cardiovascular signs, such as bradycardia and isolated diastolic hypertension. The signs and symptoms of hyperthyroidism include anxiety, irritability, sleeplessness, fatigue, restless sleep, increased appetite, a decreased attention span, tremors, proximal muscle weakness, hyperreflexia, weight loss, hair loss, palpitations, tachycardia, atrial fibrillation, isolated systolic hypertension, goiter, increased sweating or heat intolerance, blurred or double vision, dry eyes, conjunctivitis, a disconjugated gaze, an increased frequency of stools, amenorrhea or oligomenorrhea. Diagnostic conditions or parameters outlined in the BC guidelines. Causes of a high TSH, so hypothyroidism, include autoimmune. The laboratory results include a high TSH and a low T4. Subclinical hypothyroidism is typically asymptomatic and is categorized by a high TSH and a normal FT4. Recovery from non-thyroidal illnesses. Sick euthyroid syndrome. Testing is not usually indicated as patients recover. Their TSH may normalize or even become elevated. Very rare causes are pituitary diseases, resilience to thyroid hormones. These are highlighted with a high TSH and a high FT4. When this is the case, you should consult with a specialist, such as a lab physician or internalist. Some causes of low TSH include hyperthyroidism or other causes of thyrotoxicosis, clinical hyperthyroidism, sick euthyroid syndrome, and very rare causes such as central hypothyroidism. On the side, we have some of the laboratory results also listed that are listed in the BC guidelines. So pause here and take a second to note some of the laboratory results. This is an image that was also taken from the BC guidelines. It explains the diagnostic conditions and the parameters outlined for somebody who needs more of a visual aspect. Moving forward, I want to discuss any pre or post assessments or monitoring required while the patient's receiving these medications. So for hypothyroidism, the medications are levothyroxine and liothyronine. Prior to taking levothyroxine, you want to take a patient's blood pressure before each dose. You want to monitor their I and O ratio and weight every day. You also want to monitor their height, their weight, their psychomotor development, and their growth rate if it's given to a child. You want to monitor the pro time and check for bleeding or bruising. And you want to assess the cardiac status, searching for any signs of angina, palpitations, or chest pain. Change in the VS, the geriatric patient should have undetected cardiac problems, and a baseline ECG should be completed prior to the treatment. Moving forward to liothyronine, you want to assess the heart rate of the patient. You want to take an ECG and listen to any heart sounds. You also want to monitor and report signs of excessive or inadequate dosing. Drugs for hyperthyroidism include methimazole and propylthiouracil. Prior to taking or prescribing a patient with methimazole, you want to assess for palpitations, nervousness or loss of hair, insomnia, heat intolerance, weight loss, or diarrhea. And prior to administering propylthiouracil, you want to monitor a patient's pulse, blood pressure, temperature, input and output ratio. You want to check for edema, and you want to check for weight daily. You also want to monitor a patient's weight loss if they do lose weight, their nervousness, any signs of insomnia, if they have a fever, diaphoresis, and tremors. Moving forward, we're going to talk a little bit about medical management of thyroid diseases. The medical management. Specific medications can be used to treat thyroid diseases. People can improve the overall quality of their lives by implementing the appropriate medical practices into their daily routines to manage their conditions. Here I've separated the drugs used to manage hypothyroidism from hyperthyroidism. The drugs we would use to treat hypothyroidism include desiccated thyroid, levothyroxine, and liothyronine. And before moving any forward, I want to note that on this slide it does say liothyroxine. That is a mistake. It should say liothyronine. Moving forward to the drugs to manage hyperthyroidism include methimazole and propylthiouracil. What do these medications do, and what is the therapeutic effect? Desiccated thyroid, otherwise known as armor thyroid, is given when the thyroid does not produce enough hormones on its own. It's used to treat forms of hypothyroidism. Desiccated thyroid is a natural source of thyroid that is derived from animal sources. Liothyronine is used to treat hypothyroidism and decrease the size and severity of the thyroid gland when diseases such as goiter occur. When individuals suffer thyroid cancer, they may be prescribed liothyronine to replace thyroid hormones produced by their body. Levothyroxine. Levothyroxine is used to treat hypothyroidism or an underactive thyroid gland. Levothyroxine is taken to replace the missing thyroxine. Propylthiouracil is used to treat hyperthyroidism or thyroid crises. When individuals are expecting an operation, they are also often prescribed propylthiouracil. Methimazole is used to treat hyperthyroidism. It's also taken before thyroid surgeries or forms of iodine therapy. Methimazole functions to stop an overactive thyroid gland. Medication classes for thyroid disease management. So, medication classes for hypothyroidism include natural forms of thyroid dissected from animals, hormones, or thyroid agents, whereas medication classes for hyperthyroidism include antithyroid agents. The pharmacodynamics and pharmacokinetics of dissected thyroid and liothyronine. The absorption of armour thyroid takes place in the GI tract. 95% of the T3 is fully absorbed within 4 hours. Fasting increases the absorption rate. It is spread from circulating hormones like thyroid-binding globulin, thyroid-binding prealbumin, and albumin. It is synthesized through deionization and is excreted through urine. It has high receptor affinity and is an agonist. The starting dose is 30 milligrams with a 15 milligram increase or decrease every 2 to 3 weeks. The absorption of liothyronine takes place orally in the GI tract. Liothyronine is distributed via plasma proteins such as thymidine-binding globulins, thymidine-binding prealbumin, and albumin, similar to dissected thyroid. Metabolism takes place in the liver by deionization and is excreted into the bile. It has high receptor affinity, but the duration is short. It is considered an agonist, and the dosage is 25 micrograms daily. The pharmacokinetics and pharmacodynamics of levothyroxine. Levothyroxine is an agonist with moderate receptor affinity. The dose is based on body weight and is 1.7 micrograms per kilogram. It is absorbed in the small intestine, so the duodenum, the jejunum, and the ileum. It is distributed via plasma proteins and metabolized in the liver and excreted through one's urine output and feces. The pharmacodynamics and pharmacokinetics of propylthiouracil and methimazole. Propylthiouracil is absorbed from the GI tract and is distributed via plasma proteins. These include lipoproteins and albumin. Propylthiouracil is metabolized in the liver and is excreted through the urine. It has high receptor affinity and is considered an agonist. The regular dosage is 300 milligrams. Methimazole begins being absorbed directly upon oral administration and is distributed by plasma proteins. It is metabolized in the liver and excreted through urine outflow. Methimazole has a high receptor affinity and is considered an agonist. The dosage is 15 to 60 milligrams every 8 hours, 3 times daily. Here we went in more detail to describe the action, onset, duration, peak, and half-life of these medications. Once again, I'm going to let you pause here and take note on information you find important. So, what are the side effects of these medications? The side effects of levothyroxine include chest pain, chest discomfort, difficulty breathing, difficulty swallowing, fatigue, an irregular heartbeat or rhythm, heat intolerance, or a decreased urine output. Side effects of liothyronine include anxiety, body pain, blurred vision, chest pain, decreased bone density, decreased urine output. Side effects of armour thyroid include a decrease in appetite, hot flashes, shortness of breath, weight loss, cramps in the lower extremities, and insomnia. Side effects of methimazole include skin rashes, hair loss, nausea, vomiting, a loss of taste. And side effects of propylthiouracil include edema, vasculitis, hepatotoxicity, nausea, vomiting, diarrhea, a loss of taste, a rash, hair loss, skin discolorization, urticaria, hypothyroidism, glomerulonephritis, bleeding, drowsiness, headaches, or vertigo. If a client experiences any of these, they should consult their healthcare provider or their physician, as side effects regarding thyroid management medication can lead to life-threatening concerns. Thyroid storms are rare conditions that can occur when an individual's thyroid gland is hyperactive or a patient has untreated or undiagnosed hyperthyroidism. Patients taking medical management for thyroid disease should understand and recognize the symptoms of a thyroid storm, which include an increased heartbeat, increased temperature, diarrhea, jaundice, agitation, confusion, and a loss of consciousness. Why would clients be prescribed these medications? People get prescribed these medications to regulate their thyroid activity. Hyperthyroidism and hypothyroidism are two common thyroid diseases. When an individual is suffering hypothyroidism, they do not have enough thyroid hormone in their body to maintain healthy functioning of their thyroid gland. Whereas when an individual has hyperthyroidism, their thyroid gland is producing excessive amounts of thyroid hormones. This causes the body's metabolic reactions to speed up, often resulting in weight loss, fluid loss, or dehydration. Because of this, adequate medical management regarding thyroid hormone is critical to maintaining a healthy lifestyle. What are some age-specific considerations for older adults? Older adults are more sensitive to thyroid disease management. They're more likely to experience adverse reactions to the thyroid hormones used to treat their disorders. Older individuals have reduced liver and renal functioning, therefore can have implications while taking this medication. Dosage requirements differ in older adults. They often have a 25% reduction in comparison to a normal adult dosage. Drug interactions among other medications the client can already be taking can poorly impact their health. Older adults may suffer more adverse symptoms or side effects from their medications, and older adults may suffer dehydration or decreased urine output. A few non-pharmaceutical treatments for thyroid diseases to help maintain and regulate thyroid levels include increasing activity levels, including selenium and vitamin B into the diet, limiting the daily intake of gluten and other forms of sugars within the diet, increasing the intake of supplements in the diet such as L-carnitine, including probiotics and healthy fats into the diet, using tactics such as hot and cold therapy, and reducing processed and unhealthy foods within the diet. What patient teaching is indicated given your disease or illness as it relates to this medication? Levothyroxine. Teach the patient signs and symptoms of bleeding, GI bleeding, nose bleeding, and bruises. Instruct the patient to use caution when driving and in other activities requiring alertness because of drowsiness and blurred vision. Note that the product may be used without food, and to swallow the capsules whole, do not crush, chew, or break the capsules. Methimazole. Advise the patients to abstain from breastfeeding after delivery. Instruct the patient to take pulse daily. Advise the patient to report redness, swelling, sore throat, or mouth lesions. Caution the patient to avoid OTC precautions that contain iodine. Propylthiouracil. Teach the patient to take daily pulses. Teach the patient that the response may take several months if the thyroid is large. And teach the patient signs and symptoms of overdose.